From the American Neurological Association, I'm Ifra Zawar, and this is ANA Investigates. Today, we'll discuss pediatric epilepsy surgery. Pediatric epilepsy surgery has undergone a remarkable evolution, moving from a treatment of last resort to a critical option for children with drug-resistant epilepsies. Yet major barriers remain, including delayed referrals, fear of brain surgery, and uncertainty around risks and benefits. At the same time, advances in imaging, genetics, and neuromodulation are shaping the utility of epilepsy surgery. For an update in pediatric epilepsy surgery, we spoke with Dr. Ahsan Moosa Naduvil Valappil, a pediatric epileptologist and an associate professor of neurology at the Goodkin Clinic. Dr. Moosa is internationally recognized for his work in pediatric epilepsy surgery and complex hemispheric epilepsy syndromes. Dr. Moosa and his colleagues at Cleveland Clinic have helped advance our understanding of how surgical interventions can improve outcomes for children with epilepsy. Dr. Moosa was interviewed by Dr. Howard Goodkin, the Shure Professor of Neurology and Pediatrics at the University of Virginia. Here is Howard.
Welcome, Moosa.
Thank you. Thank you, Dr. Goodkin, for having me for this podcast. Thank you for the kind introduction.
I've been really excited about this opportunity to speak with you today and gain additional insight about pediatric epilepsy surgery. I think one of the things that frustrates me is the well-documented lag between when a child develops drug-resistant epilepsy and when they're referred for surgical evaluation. Can you share with us your thoughts about what's driving that lag and what you would say directly to the general pediatric neurologist who happens to stumble upon this podcast?
You are absolutely right, Howard. The average delay from epilepsy onset to surgery has been reported to be close to 18 years. It's in several studies from United States, Germany, India. We have seen the same thing in our hemispherectomy series in adults and adolescents. More than 95% of the patients who underwent hemispherectomy in adults had their disease in childhood, but they did not undergo surgery until adulthood. Now, people often attribute this to a knowledge gap and a feasibility gap, thinking that it's not feasible in certain resource-poor countries. But what is striking is the delay is not dramatically different between resource-limited settings or resource-rich countries. That suggests to me that there are other factors at play here. I think the two important contributors are an experience gap and an enthusiasm gap. And what I mean by that is the fear of brain surgery is real and fear of epilepsy surgery is much more real. Brain surgery for tumor removal is acceptable for everybody. But when you're doing for epilepsy, it produces a different kind of a fear. The idea of removing or disconnecting part of the brain is intimidating, especially for neurologists who do not regularly see surgical patients. And if your exposure is limited to the risks of surgery and not the long-term outcomes, it is easy to overestimate the downside of surgery than the upside. What changes perspective is experience. Seeing children becoming seizure-free, returning back to school, developing normally, developing to their potential, and living fuller lives after surgery is incredibly powerful. Most patients do not experience the devastating cognitive consequences that many people fear. In fact, the net benefit is often substantial. That is why I encourage my surgical patients to maintain contact with their referring neurologist to have a first-hand experience of the outcomes after surgery. Once that experience develops, enthusiasm follows. Personally, when I see a child who has failed an appropriate anti-seizure medications, even the first appropriate anti-seizure medication, surgery is already somewhere in the back of my mind. And if there is a potentially amenable lesion, I may begin discussing the concept of surgery much earlier, even at the first visit. And if they have a focal cortical dysplasia and a focal epilepsy, I may prepare them for surgery right at the get-go. The message I would give to the neurologists and pediatricians is simple. A referral for surgical evaluation is not a referral for surgery. It is a referral for expertise. Let an experienced epilepsy surgery team assess the risks, benefits, and the alternatives. And of course, we would not recommend surgery unless we strongly believe that it is a reasonable choice, or rather it has a reasonable choice of making the child's life better. The greatest risk is often not an unnecessary referral. It is years of uncontrolled seizures while waiting for the surgery.
I love that answer, and especially how you framed it as our willingness to quickly remove a brain tumor and maybe hesitancy in doing epilepsy surgery, as well as the idea that it's a referral and not a definite surgery. In your answer, I think I want to tease out a little bit more about neurodevelopmental consequences of seizure burden in childhood and the negative impact of waiting to make that referral. So, is there a critical window argument for surgery that we underutilize?
Absolutely, absolutely, yes. I think the concept of critical window for surgery is particularly important in children. In the context of surgically remediable epilepsies, the ongoing seizures have a substantial negative neurodevelopmental consequences. Most large studies have shown an association between the duration of epilepsy before surgery and seizure freedom rates. The seizure freedom is better with early surgery. And by stopping the seizures, we are stopping the ongoing negative impact on the rest of the brain. One other thing in children is the concept of neuroplasticity. Simply speaking, neuroplasticity is the ability of the remaining parts of the brain, particularly the homologous areas on the opposite side, and their ability to develop the lost functions. And this is probably best studied with regard to language in young children. So the children with the loose language due to a lesion early in life, they develop these language abilities on the opposite hemisphere. This window of plasticity gradually closes after 5 to 6 years of age and declines rapidly after 6 to 7 years of age. And I can explain this in a clinical scenario. Actually, I saw this patient yesterday in the clinic 2 years after surgery, and the child is now 7 years. And he was 5 years old when he had a left hemispheric Rasmussen encephalitis. He was developing previously normal. He was right-handed, presumably the left hemisphere was language dominant. And I encourage them to proceed with hemispherectomy sooner than waiting around with trials of immunotherapy. In fact, I felt an urgency to do it at 5 years of age rather than waiting longer. We all wish that Rasmussen could be responsive to immunotherapy, but unfortunately, most patients do not. And if we do an immunotherapy trial, it may delay the inevitable surgery by a couple of years. If the child undergoes hemispherectomy at 8 or 10 years, we are losing the window of plasticity. So that child had undergone surgery 2 years ago, is doing remarkably well with language trajectory closer to his age. So should we do surgery in well-controlled epilepsies? There is an idea that is emerging. And if you look at the ILA recommendation from the Surgical Commission in 2022, they recommended that patients with an appropriate epileptogenic lesion in a non-eloquent region could be considered for surgery, even if they are well controlled with 1 or 2 medications. This is particularly applicable with focal cortical dysplasia or low-grade tumor, because surgery becomes inevitable over time. But if the seizures are well controlled, the patients and family are hesitant, it is okay to wait. But in children with drug-resistant epilepsy, if surgery is an option and indicated, it is usually the best option.
So I think in some ways, especially that discussion about should we be doing epilepsy surgery in well-controlled where we know there's an epileptogenic lesion, I think raises for me the question of how do we think about outcomes in pediatric epilepsy surgery and what matters most? Is it the neurodevelopmental outcome? Is it the controlling the seizures? And has what matters most changed over time?
That's a great question. The primary goal of epilepsy surgery is almost always seizure control. I have rarely recommended surgery for other reasons. Any other improvements that occur, whether in cognition, behavior, quality of life, or development, are very important, but they are often downstream benefits of achieving a better seizure control. So when we look at developmental outcomes, if you look at large pool of surgical candidates in children, 70 to 80% of children remain cognitively stable after surgery. 10 to 15% improve, and another 10 to 15% there is a potential for decline. Okay, we can predict these patients based on their phenotype, the type of surgery, what kind of the neurocognitive function they have to begin with. The most important thing that determines the developmental trajectory is the developmental status before surgery. But what we do know that the development is optimized when the seizures are controlled. And there are several studies that have shown there is a decline of roughly 1 to 4 IQ points per year in the period leading up to surgery. This gets stabilized and children have greater gains when they become seizure-free, particularly when they become medication-free. That's also another factor that has been shown that to optimize the developmental outcome. And of course, we're talking about seizure outcome, developmental outcome, but one should also focus on quality of life. I remember a girl in my practice, maybe 7 or 8 years ago. She had bitemporal epilepsy, but she was having frequent seizures, frequent emergency room visits. And we decided to go after one side to reduce the seizure burden. After surgery, she continues to have 2 to 3 seizures a month. So on paper, the outcome was far from perfect. But years later, the family remains deeply grateful for the outcome because she has not needed a single ER visit since the surgery in the many years. The quality of life for both the child and the family has changed dramatically.
Musa, when you get the referral from the pediatric neurologist or a second opinion regarding epilepsy surgery and the hesitancy about pediatric epilepsy surgery potentially from the family, how do you talk about the risks versus the benefits?
Most patients who undergo surgery, 70 to 80% of them, we do not expect any deficits. There may be a 10 to 20%, there may be a predictable new deficits, and whether it's acceptable or not depends upon the type of deficit and the burden of seizures and what is existing functionality in that child before the surgery. As I said earlier, there is a lot of hesitancy about doing epilepsy surgery. Any surgery or any procedure, we talk about risks, benefits, alternatives. But sometimes we forget about one other thing, the risks of not doing something. And that always should be emphasized. If you don't undergo this epilepsy surgery, what is your life going to be down the road? And the risks are very individualized. There are certain areas of the brain you could operate without any predictable consequences. There are other areas of the brain that has got a predictable loss of function if the child already has good preserved function in that region. Let me share an experience from 3 patients I took care of. They were aged between 8 to 12 years. All of them had Rasmussen encephalitis. And all had enormous seizure burden, frequent motor seizures, repeated hospitalizations, and their progressive hemispheric atrophy is consistent with Rasmussen encephalitis. But unlike many patients with Rasmussen encephalitis, none of them had a motor weakness. If they had a motor weakness, these children automatically undergo hemispheric disconnection. And we know the most effective treatment for seizure control in Rasmussen is hemispheric disconnection. The challenge is that the decision is never ours alone. It belongs to the patient and the family. In these cases, the seizure burden often becomes the tipping point. For my patients, the seizures were enormous and they were ready to accept the hemiplegia that followed after the surgery. And the important detail in these 3 patients is all of them had a right hemispheric disease and the language was not at risk. That matters. Complete loss of language or a global aphasia after surgery is a very different conversation. It is not acceptable for me as well as for many patients and families. What helps for families is shifting the discussion from the deficits alone to an overall quality of life. The choice is often not between a normal life and a deficit. It is between an ongoing disabling seizures that puts your life on hold versus seizure freedom with a predictable deficit, if the deficit happens. That can be addressed through rehabilitation and adaptation.
Thank you for that answer, Musa. Thanks. I want to take a little bit of a pivot here. I think one of the great advances during my career has been the increasing identification of pathogenic variants and the role that genetics plays in epilepsy. So, as we identify more genetic etiologies, how does that change your threshold for thinking about surgery versus medical or eventually targeted therapies?
That's a very interesting question. We do feel in our practice that the expanding identification of genetic etiologies is reshaping the decision framework for epilepsy surgery in some situations. Genetic data should be viewed rather as a complementary, not as replacement for standard pre-surgical evaluation. Still, the clinical history, semiology, EEG findings, imaging remain central to the surgical decision. But in some situations, genetic findings actually strengthen the case for surgery. And the best example is a group of focal epilepsies related to the mTOR pathway influencing genes, TSC1, TSC2, DEBDC5, and there are other genes in the mTOR pathway. And these are among the most surgically amenable genetic epilepsies. There was a recent systematic review of children who have lesions with genetic variations in mTOR pathways. Close to 60% are seizure free with epilepsy surgery. In the subgroup of DEB-DC5, the success rate is even higher, closer to 90%. So, some situation genetic findings strengthen the case for surgery. But on the other hand, there are channelopathies and synaptopathies like SCN1A and SCN2A and many other genetic conditions where the epilepsy is rather a diffuse network disorder rather than a focal epilepsy. And even when some degree of focality appears to be present in these patients, surgical outcomes are generally far less favorable in these patients, and they are less likely to be candidates for resective surgery. Perhaps the most exciting development in certain genetic diagnosis is their direct influence on treatment selection. Some guidance to medication choices, some conditions tell us which medication to avoid, and there is a growing number of what is called a precision medicine or a disease-targeted therapies. This is allowing us to move towards an individualized treatment approaches. And we are learning a lot about the neurobiology of the diseases by looking at the genetic variations in the brain tissue we remove during surgery. So rather than saying that the genetic testing lowers or raises the threshold for surgical access, genetic testing rather helps us to better identify the patients who are more likely to benefit versus not.
Thanks. And clearly much more to learn in the area of genetic epilepsies, and I do expect great advances in the near future. Now, if we look back at the evolution of pediatric epilepsy surgery, what's one assumption that you think we got wrong early on?
That's a very important question. One of the biggest assumptions we got wrong was that the pediatric epilepsy surgery should follow the same selection principles used in adult with focal epilepsy. Early on, the focality was considered essential. We looked at the focal features in semiology, focal EEG abnormalities, and if we saw a concordant focal lesion, the case was solved. In children, the same principles were applied. If the epilepsy looks generalized, surgery was not an option. That was the thinking in our 80s and probably early 90s too. Because of the result, many children with epileptic spasms, Lennox-Gastaut syndrome, and the symptomatic generalized epilepsies were not considered as surgical candidates, even when they had an obvious structural brain abnormality. The major shift in this thinking came originally from UCLA, who demonstrated that children with epileptic spasms and focal lesions could benefit from surgery. But even then, early on, they required focal EEG findings to consider these patients for surgery. But over time, experience from centers like Cleveland Clinic, and Dr. Wiley was one of the pioneer in advancing this particular field. We showed that even in the absence of focal EEG abnormalities, patients could undergo surgery in the presence of an appropriate epileptogenic lesion. So that was a major change in thinking. We came to realize that the terms like generalized epilepsy is often describe the phenotype rather than the true underlying biology. Many of the children with epileptic encephalopathies, the epilepsy was driven by focal or hemispheric structural abnormalities, which are surgically remediable. Today it seems obvious, but it was a profound conceptual shift in the 90s. And we moved away from asking, is this generalized or focal, to asking what is driving this epilepsy? And is this something that is surgically remediable? That changed our ideas and thinking and opened the door for surgery for many children who previously would have never been considered as candidates. I think that was a major shift that probably contributes to around 20%, 20 to 30% of children who undergo epilepsy surgery.
Moosa, I agree with you 100% on that point. And I think it does emphasize the need for all of us when we see a patient with a generalized epilepsy not to completely discount the idea of whether a surgery may be helpful for them. So now looking at the field over the next 10 years, what advances, whether neuromodulation, gene therapy, closed loop systems, or something else, do you think will fundamentally change how we manage pediatric epilepsy?
You listed a lot of approaches that I'm hopeful for: gene therapy, neuromodulation, and of course, new medications. I'm sure these things will expand our ability to help children with epilepsy. But if I have to choose one area that excites me the most, it would be gene therapy. I started my neurology training in 1998 in India. At that time, infantile SMA was considered as untreatable, devastating disease. And I never imagined that I would one day see a child with SMA running around like other healthy children. And recently, I saw in the clinic a 4-year-old child who was identified with 2 newborn screening, treated with gene therapy in a county hospital. And that child was running around like any other 4-year-old. It was one of the most joyful moments of my career. I wouldn't have expected a non-epilepsy scenario would make me so happy. So that experience makes me optimistic about gene therapy. The gene therapy trials are already underway for conditions like Dravet syndrome. And I think we will see meaningful advances in several childhood epilepsies with epileptic encephalopathies, with monogenic genetic conditions in particular. And some of these approaches may eventually extend to other focal epilepsies, which may not be thought as genetic at this time. In fact, our center is participating in a trial involving gene therapy for patients with hippocampal sclerosis in adults. Who would have thought that? This idea that we might someday stop seizures without removing or disconnecting brain tissue is remarkable. I think gene therapy has a huge role. About the other things you mentioned, the neuromodulation, I think neuromodulation continues to evolve and advance, but I suspect there may be a ceiling for its impact. At this point, most of the times we are reducing the seizures and not completely eliminating. In one of the grand rounds, one of the senior epileptologists remarked about an adult patient who may spend less than 60 minutes a year actually having seizures, but spends the rest of the year worrying about the next seizure. This observation has stayed with me. In that regard, I think seizure forecasting may ultimately be very useful, as useful as neuromodulation. If can reliably predict seizures before they occur, we may be able to fundamentally change how patients live with epilepsy. And as for the medications, I have seen a ton of new seizure medications over 25 to 30 years, but the proportion of patients who are drug resistant has not changed a whole lot. Because of that, I'm less convinced a single breakthrough medication would dramatically alter the landscape. I hope I'm wrong. And again, if you ask me what will most fundamentally change pediatric epilepsy care, my answer would be gene therapy. Unlike many other treatment, its potential ceiling is not yet visible. And I think with time, it will continue to improve and ultimately allow us to treat conditions which we think are untreatable at this time.
Musa, thank you for your time today. This was a great learning experience for me. And I hope the ANA will invite you and I back 10 years from now to look at where the field has changed and the role that genetic therapies have played, and relook at this last question again and see how spot on you were.
I hope I'm right.
Yeah.
It would be fun to talk about this subject again in 10 years. Maybe we should have a prelude of this session into that session.
Thank you, Musa.
Okay. Thank you, Howard.
That was Dr. Ahsan Moosa Naduvil of Cleveland Clinic, interviewed by Dr. Howard Goodkin of University of Virginia. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Sarah Nelson and Sharon Ellen Govan. I'm Ifra Zawar, the podcast host and executive producer. Our production team this month included Howard Goodkin and Jen Hurley. You can listen to the past episodes of the show, subscribe to us so you never miss an episode again, and access all of the ANA's educational programs on the Education tab at myana.org. That is it for ANA Investigates. See you soon.